Welcome, everybody. My name is Dr. Margaret Gavian. I'm a psychologist here in the cities, and I come after 10 years of working primarily only with first responders, many types of first responders, but firefighters primarily, some law enforcement, 911 dispatch, healthcare workers of all types. So I'm curious if you want to pop in the chat how you landed here. I've also done plenty of trainings for providers who are interested in this population. So if you're watching online, please let us know who you are and how you landed to be in this room tonight, and welcome everybody sitting in the room. How many people are first responders? All right, so that's good because I am used, so there are a lot of hands. So I'm used to talking to mostly people in departments, and so I'm going to apologize ahead of time if my language might seem crass, if I might use a curse word, because it's kind of the way I roll these days with talking to people out there in public safety. How I got into this work is, first of all, I trained as a firefighter EMT 100 years ago in my hometown of Arlington, Virginia, just for funsies. And I also had a job running mental health programs in war zones. So for soldiers, civilians, I kind of built like you, have a little bit of the adrenaline bug and wanted some adventure. And that's how I got my start and interest in diving into the world of trauma. You know, not to mention that I'm human just like all of us. So I come with my own lived experiences. My father was in the military. My kid's grandfather on the other side is a retired firefighter. So both personal and professional is how I arrived to this work. And then professionally, about 10 years ago, I was approached by an organization that was being developed for firefighter health disparities, the Minnesota Fire Initiative. Many of you might know that group. And they asked for some clinical direction to do their peer support training and help monitor their crisis line in the beginning. So we were on the end of that phone call when people were calling in. As we know, many first responders have higher rates of mental health issues. I don't think of them as disorders, and we're going to talk about that. Why I think that today, because they're physical issues, not just some sort of problem up in our mindset or in our personality. And after years of listening to the kinds of calls that had people asking for help, I decided this is what I need to do. I need to pivot. I was working at a large hospital system at that time, pivot and focus on how do we keep first responders resilient? How do we keep them well? How do we help them deal with the things they have to see and do on a normal basis that is beyond what the rest of us normie civilians need to do? And how do we keep people feeling good in a job that tends to grind people down? Since then, I've also been doing a lot of things for healthcare workers, surprise, surprise, and also applying everything I'm going to talk about to my own life, to those people in my circle, because we all, doesn't matter who you are, if you're a first responder, if you're a healthcare worker, if you're a teacher, if you're a behavioral health provider, if you're a single mom or a normal parent just trying to juggle all the responsibilities, many of us are moving at a clip that we are really not designed to live in. And I think we all know this inherently, but we're going to talk about today what that looks like when we're living in what I call go mode all the time, and how we pay a price for that and how we can start turning the ship. So many of you might notice that you can work a shift, a day, or even on your downtime or your weekend, that you still feel like you're on, right? Like, what's next? What do I have to do next? Where's my to-do list, right? I got to keep moving. I don't want to slow down, or it doesn't feel good to slow down. I know I need to go to bed, but my mind is still on, right? I can't get my mind to shut off, right? And especially if you're someone who works in healthcare or in public safety, those kind of jobs don't just take your time, right? That's not just, I did my shift and now I'm going home and poof. And it doesn't really matter if you're police, if you're dispatch, if you're paid on call fire, if you're full-time career fire, right? All of the way that those service jobs are oriented is give, 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 output, output, output. And we love that. And we need you and thank you for doing that. And our nervous system takes a hit for that. It doesn't matter if it's my dog dying or some other tragedy occurring in someone else's life. It really has to do with that our bodies are wired and stress happens to all of us. It's just, and we all respond, and the nervous system responds in the exact same way, right? It's just, if people are in stressful, high stress environments, they have a lot more coming at them that they have to figure out how to deal with. So you're designed to be in go mode. It's probably why you chose a profession like this. You liked the action, you like being useful, you like being thrown into the chaos. I know I certainly do, and I can relate to that. And that starts to become normal, and you learn through your training how to respond appropriately in all of these kind of high stakes environments. But no one talks about what you do when you get off shift, because you just, take your uniform off and go home and tend to your next adult duties. So we're not very well trained for how to go into that off position. Anybody notice that? Yeah, right? Sometimes I'll hear from people who call in, like, I don't really know what's wrong with me, but it's kind of like a hamster wheel of life. I just get up, I do my stuff, I take care of the to-do list, I take care of the kids, my family responsibilities, or I'm up at work doing what I need to do, but it's the hamster wheel of life. And I never really feel calm or relaxed unless it's hunting season. And then we mostly stop noticing that we're living in that go mode. So we're responding, we're dealing with the kids, we're dealing with the family obligations, we're dealing with the neighbor who asked for this, and the community that asked for this, and the department who asked us to sit on that other committee, and this other request that came in via email. And we're tired, we know we're tired, but that just becomes our baseline. So it's not like we're sitting on the beach with our feet up with a Corona in hand anymore. And rarely do we even have those moments, even, dare I say, if we're on vacation, right? We just start to feel like, well, this is normal. I'm just used to living in this type of go mode. And we like it, right? It feels kind of addictive. It's fun, right? It's why we see, anybody ever see that old movie, now I'm aging myself, called The Hurt Locker, right? So, and you see like people redeploy to war zones, not because they love war, but because they're useful and because we're focused in those environments, right? We don't have to think of the 400 cereal boxes in the aisle that we need to decide between or deal with the mundane little parts of life, right? We like if that adrenaline feels good, right? And then if I ask you how you are, and how many of you guys do this in your normal everyday, you say, I'm fine. Fine, right? I'm good. The world's not burning down right now, so I feel pretty good. I'm just doing fine. It's like the normal. Does anyone know what FINE stands for? I had a mentor of mine a long time ago tell me that. Does anybody know? Okay, I might curse in this part, but maybe I'll edit myself, right? Effed up, insecure, neurotic, and emotional. So my challenge to you is next time you feel the inclination to tell someone you're fine, think of a different word. Right? Maybe you're maxed out. You call out a friend when they tell you that they're feeling fine. But that just becomes our default. Another thing, sometimes we hear people will say, live in the dream. When I hear that, I think, what dream is that? Because people say it is kind of like a funny cover up, right? So when we're staying on, and we stop really noticing that we feel exhausted, or we just know and we keep moving, eventually this starts to have a toll on our mind, body, and spirit and our life. The first thing people notice is that their sleep starts to be affected, right? I come home, I'm tired, I know I'm exhausted, and my brain is just about nothing. Or I wake up, this is how I hear it, I keep waking up at 3 a.m. for no reason. I don't know why. I'm not thinking about anything in particular. It's just junk that I'm thinking. And I'm not really anxious, but why is my brain doing that? Another thing that I hear a lot about is irritability, right? Those years ago when I was on the crisis line, the way those calls would come in is, I'm yelling at my kids and I don't know why. What is wrong with me? One chief called and said, I'm hiding in my own garage when I come home because I don't like who I am around my family. I'm blowing up at my kid for no good reason. There's another story I know of a seasoned firefighter who had little kids at home, and on an off day, and they're heading to grandma's house. There's absolutely no rush. And that firefighter called and said, my wife told me I have to call, otherwise I'm in trouble. Because as we're trying to get out the door, I'm yelling at everybody like there's an emergency going on. And my wife simply stopped and looked at me and said, hey, we're going to grandma's house, chill out. But my 2-year-old won't get their socks on. The 5-year-old's over there doing God knows what. And I'm freaking out inside, right? Because his body was still in this go mode, even though, right, his family wasn't, right? So it was starting to create friction inside the house. This is how a lot of times people are arriving or asking me in stations and otherwise. So, or the opposite happens. Sometimes I've heard, oh, well, my family tells me all the time I'm a robot, right? Or my family tells me I don't have any empathy anymore, right? Anybody hear that one, right? Like you don't really see, you don't get bugged when your kid scrapes their knee or falls down and there's a whole big to-do and you're kind of like, no, you're fine. You're not injured. We don't need to go to the hospital. So no big deal. Or eventually, sometimes people start to feel burned out. And then one of my favorite, right? People say, well, this is the job I signed up for. This is just how life is. This is just the way it is. There's nothing I can do about it. And I really want to challenge that notion because if we don't do anything about it, we know where that goes. We're going to get to that in a second, but I'm guessing you also know where that goes for you. For me, it happened when I had an injury, and then I realized my body couldn't keep the pace that my mind and my activity level was used to keeping. So I had to sit, kind of on the bench while my internal state was still moving really fast, but my body couldn't do what I was normally used to. And then I had to look at my own nervous system. What's happening inside that you feel this amount of antsiness, like you should be resting, or you go on vacation and you feel like you can't really totally relax. This isn't because there's something wrong with you or you have a weakness. It's simply a nervous system that has too much load. So I want you to think about, when you think about the life that you're living, your particular circumstances, whatever it is, it doesn't have to be being in public safety. Where do you feel the effects of staying in go mode? Does it show up in your body? Does it show up in your emotional state or how you relate to the people you care about or even to the dog? Does it show up in how your energy levels are being affected? Feeling like you're dragging yourself all the time? Or, dare I ask, how much joy might you be experiencing? How much happiness is there in your life? Or are we kind of just like, holding it all together and hoping things don't crash and burn? So we can't help regulate and address what's happening in our nervous system if we don't first start naming it and identifying the price that we're actually paying. Many high-performing people, and I talk to a lot of high-performing people in their professions and in their lives. They're very functional. They're holding everything together. They'll say, I'm good, I'm good, I'm good, I'm good, until their body craps out. And then they realize, maybe I'm not so good. So we're going to talk about that and why that is today. So when I first got into this work, I came at it from a trauma perspective, and I still do. That's still very much true. But I had done a lot of research and a lot of learning about how to treat post-traumatic stress. I don't call it a disorder anymore. That's for insurance companies so providers can bill, but it is not a disorder. It is an injury to the brain and to the nervous system, which many of us have experienced, right? So I thought, I'm going to go and I'm going to help everybody fix their trauma, right? We're going to put memories where they need to go. And public safety especially, they've got a lot of those memories. So there's going to be a lot of things that we're going to have to talk about. Big car accidents and crazy fires and wild situations out there on the streets. Until one fire department schooled me pretty hard. And he said, listen, doc, like, thank you for coming. Yes, sometimes we're on those calls, but it's not really always about those bad calls. Yeah, those stick and some of them hurt, but it's really about the BS stuff in between. The stress within our organization, sometimes dynamics, relationship dynamics that are happening either at home or amongst each other or around our coworkers. So while, we need to address the traumatic parts, this is really about, can you help us how do we stay well when we've got those calls at 2 a.m. for a toe pain that piss us off and we're being run ragged by the everyday grind of shift work, for example. So this is really about how do we build a system of caring for ourselves, of being our best selves, of helping our mind, body, and spirit stay in a healthy or content place, right? And that's a system. Resilience is a muscle that we have to practice. It's not necessarily something you're either born with or you have or you don't have, or a personality characteristic. It's something we have to practice on how to address things happening in our body, like sleep. I know when I mention sleep, many people roll their eyes, especially if you're a shift worker, because you think, well, I'm screwed, there's nothing I can do. But allowing for recovery time. Yes, shift work is very hard on the body and the nervous system, and there are still things you can do to improve it. Most of the time, I find that people don't allow themselves to recover. They just kind of get on to the next thing. They don't allow space for recovery time. It also has to do with what happens up here in your mind, right? How we think about things, if we even know what we're feeling. A lot of us don't actually know. We know we don't feel good, but we don't know why. So building awareness of how we might be thinking, how we might be feeling, and having language around those things. And then also the spirit part. Now, I don't necessarily mean religious or having faith-based beliefs. Sometimes that is true. But often the way I think about addressing the spirit is where you feel connected, where you get your purpose, your identity, and where you feel like there's something larger than yourself. So there's no one quick fix here. We can't all just run and get EMDR and be cured forever and ever, or take the latest, greatest supplement and be fixed, right? This is kind of a whole person approach that you need to think about for yourself. I mean, sleep, if there was one quick fix, it would be sleep, but that's not always possible either. Feel free also to pop in with questions, especially those of you online, if you have a comment or question. We welcome any of those. All right, so there's not gonna be a science quiz, but I do wanna explain the basics of biologically what's happening, especially when we're in go mode. So imagine, wherever you are, that a rabid dog comes barreling through the room right now. And if that dog came barreling towards you in this exact moment, what would you do, right? So you might, law enforcement, you might go for your gun, right? Or I might grab a chair, and I might also, you might notice, oh, there's a door back there. Okay, so the dog's coming this way, there's a door back there, and might I get up, right? How might I stand on a table, find something I could use as a weapon, right? And I don't have to think about it. So it's not just like a normal evening, we're all at this very nice talk, right? We don't even have to think. It's boom, our body responds. And that is our autonomic nervous system, of which there's two parts. There's pedal to the metal, right? The gas, like, okay, it's go time. I don't care what I had for dinner. There's a situation here and I've got to take care of it, right? And a whole bunch of things happen in your body when that happens. Right, like blood pressure goes up. Yes, like breathing also goes up, right? Heart rate, and our digestion stops. So the body says, don't really care what you had to eat. There's a situation, we got to deal with it right now. There's some other things that happen too. Pupils. Those of you guys who work on the streets or have patients, right? When you look at them or you touch their hands, what do they feel like? Cold, right? Their hands might be cold and clammy because their circulation has changed. Circulation has gone to the core and away from our extremities. Pupils dilate. Where are my exits? Where are my weapons? How do I get out of here? And who has children? What might they say before a big game or a big test or a play that they're in? Yeah, Their tummy hurts, right? Their tummy hurts because our digestive system is affected when we are thinking about the big scary dog. So law enforcement takes care of the dog. Dog is subdued. We're all good. It can come back down off the table. And then the brakes of our body set in, right? The parasympathetic nervous system kicks on, which is designed to bring everything back down to normal, right? That's where rest happens. That's where we recover. Circulation picks back up. Our heart rate slows down, right? Our pupils go back to a normal size and our blood pressure goes back to normal. All of these things happen without us having to think about it. Oh, there's a situation. Might be the call from our mother-in-law or a bill in the mail. Doesn't really matter. It doesn't have to be survival. But if the body feels that ampedness, could be a fight with a loved one, right? This happens, pedal to the metal, and then when it's done, when it's taken care of, the parasympathetic nervous system kicks on. But what happens with a lot of us, right? We're all thinking about the dog that happened last year, last month, 20 years ago, or that other dog that might come next time, right? And we can keep that nervous system in the on mode even when there's no dog, or even just by imagining the dog. And we don't really ever learn how to hit the brakes. We don't really learn how to actually decompress our system and reset it. So we end up just living in go mode. So here's a picture of your nervous system. I like to show this picture because sometimes people think, oh, it's just all in my head. I have to think something different. I have to not be stressed out about that thing. Or I should just be over it by now. But it's not just a thought, right? What's happening is a full body response. And this, if anyone saw the bodies exhibit that's come through, now it's been a long time ago that it came through St. Paul, but you can catch it in other parts of the country. This is what your nervous system looks like. So from head to toe and everywhere in between, every system is affected. So when we think about that dog from 5 years ago, this is what is happening. This is everywhere in between. Your immune system or all your hormones, many different systems within the body are being affected, and our brain is on high alert. We're going to have to hear a little bit more about some of the brain health later, but we start scanning for, oh, is that a dog? Oh, that thing looks like it could be a dog. I bet it's a dog, right? We start scanning for danger, and our brain is on hyper alert. So even when your kid says something pretty inane or just very neutral, you might respond like, So we start to get in these habits of scanning. And I know working with first responders, number one, is kind of hard because you're trained to scan for your own safety and for the safety of the public. You're looking, cops will say, I notice where everyone's hands are. Firefighters will know where cars are and where buildings are and know what's happening. So that's all happening in the background, not because you're faulty, but because the nervous system is in that on. We got to keep things going here. And it doesn't really shut off just because we went home from work that day. And our body, and I've certainly learned this from my own personal experience, the body reacts sometimes faster than we even know how to make sense. So I don't even know why I was in this space and now all of a sudden I feel panicky or my chest feels tight, but I don't really know why. But your body did. Right? Your body figured out there was something that reminded it of that certain situation. So the fastest way to interrupt what's happening in the nervous system is through breathing. We can control our breath. There are a million different types of breathing. So there's no one right way. A lot of people I talk to know box breathing. And if you don't know what box breathing, it's just really breathing in, out. So you make an imaginary square. It doesn't matter how short or long those are, but longer is a little better if you can get to that point. Or, as you can see here, having a little bit longer of an exhale. So it could be breathe in for 3 and out for 6, right? That helps start to kick the nervous system to where it needs to go. There are many types of breathing, but these are just a few examples. And again, it's not going to be the magic fix for everything, but it is going to help start to realize like, oh, yeah, I stopped breathing. I mean, of course you didn't stop breathing, but many times when I'm talking to someone, you can see, especially when they're talking about something going on in their life, just notice that, oh, I'm not breathing. Or if I'm driving in traffic and somebody's annoying me, notice like, oh, I've kind of started breathing more shallowly. So as soon as you notice that, just try to get a deeper belly breath in. So when we stay in that mode, right, and our body thinks that this is just normal, this is just our normal life, right, where normal conversations with our loved ones, normal traffic situations or social media, for example, but our brain is scanning for threat, like, oh gosh, oh, that person's out to get me, or that person is annoying, right? And our body is just in this amped mode. And then when you step on a Lego, right, it's like, boom, I exploded. And why am I exploding? It's just a Lego. And yeah, it hurts, but my reaction is a little bit out of sync with what really was going on. That's usually because the nervous system is, buzzing up here. Cortisol gets affected, our hormones get affected, we start having more inflammation in our bodies, and we're frankly more prone to getting sick. So if my brain and my body is worried about the dog at the door, and I touch a doorknob, a random doorknob at the grocery store, wherever I might be, my body can't fight that illness because it's worried about the dog, right? So people will say, I'm getting sick more often, I don't know why. Or I'm having more joint pain. I'm not sure why. That often happens. Chronic illnesses start to show up because everybody's body will give at some point, and everybody's give is a little different, right? So somebody's give might be anxiety. Someone else might feel depression. Anxiety, depression, chronic illnesses, just the same as a diabetes or another sort of chronic illness going. But our brain is scanning for threat, like, oh gosh, oh, that person's out to get me, or that person is annoying, right? And our body is just in this amped mode. And then when you step on a Lego, right, it's like, boom, I exploded. And why am I exploding? It's just a Lego. And yeah, it hurts, but my reaction is a little bit out of sync with what really was going on. That's usually because the nervous system is, buzzing up here. Cortisol gets affected, our hormones get affected, we start having more inflammation in our bodies, and we're frankly more prone to getting sick. So if my brain and my body is worried about the dog at the door, and I touch a doorknob, a random doorknob at the grocery store, wherever I might be, my body can't fight that illness because it's worried about the dog, right? So people will say, I'm getting sick more often, I don't know why. Or I'm having more joint pain. I'm not sure why. That often happens. Chronic illnesses start to show up because everybody's body will give at some point, and everybody's give is a little different, right? So somebody's give might be anxiety. Someone else might feel depression. Anxiety, depression, chronic illnesses, just the same as a diabetes or another sort of chronic illness going on. Okay. Well, we talked about the I'm fine. I'm fine usually means I'm running on fumes. That's the nice way of putting it, right? But in this slide, what I like about this is that when you ask people where they feel emotions, this is what people will say, right? So there are parts of our bodies that are correlated. When we feel love, for example, we get all warm, and this is what lights up. Right? Depression, not so nice, right? It feels cool and kind of empty, right? So it's important to start noticing what is happening in your own body. What do you feel? Okay, so there's a lot to this, and I don't need to hit it too hard, but I got really excited a while ago because after talking to hundreds and thousands of responders, what I started hearing was very similar. I can't sleep, my hormones are jacked, I have this medical issue going on. Yeah, I've had some TBIs from a while ago, and my body doesn't feel right, and I also deal with some anxiety. So it started to become this constellation of symptoms. And lo and behold, some other people have noticed that too at the University of Hawaii, and they named it operator syndrome, studied by looking at special forces in the military, right? Chronically stressful environments, exposed to trauma, had a multi-system impact on people's brain, body, mind, and life, and how they were living it. There wasn't any one thing. It was kind of all of those things. And what makes people good at high pressure jobs can often work against you. So they started studying that and looking at the constellation of symptoms that were so common in these high pressure environments. And now they're working on naming something called the Firefighter Syndrome. But very similarly, right, we see the same, and you guys know this if you work in public safety, it is just a normal part of the conversation. My knees hurt, my shoulders hurt, I can't sleep, I can't think as clearly, or my brain gets stuck on certain things, or, my family is kind of over it and there's some strain there. It's not always just PTSD, right? Or I have an anxiety issue. It often shows up in all areas. So besides breathing, if you can focus on your sleep, there's wonderful little gadgets, Garmin's, Oura rings that helps to measure and to see what's actually happening. Starting with minor tweaks, you don't have to overhaul, but just poor sleep alone. And if anyone's read Why We Sleep by Matthew Walker or seen any of his YouTubes, I highly recommend it. It'll freak you out. But even a night of not sleeping puts our body in that go mode, right? I'm not even talking about what we might see and do as part of our jobs. But there are things you can do, right? When we have kids, we know this very well. We read them stories, they take a bath, they change into their jammies, they might get a massage or get tucked in, or we might have a song. We do all that for kids, but what do we do as grown-ups? We do all of our chores, and then we toss ourselves into the bed and just hope we go to sleep, and then we're like, oh crap, I gotta go to bed, and oh no, now it's midnight, right? So we wanna start looking at tiny ways to tweak that. Here are some ideas. There are many more ideas than this, but especially if you're a shift worker, thinking about getting daylight into your eyeballs right when you wake up. So going outside, maybe having your cup of coffee outside or with a dog walk, or delay putting sunglasses on so that you are making sure that that sunlight's getting into your brain to help reset your circadian rhythms. And if you're a shift worker and you got to work, sleep during the day, do what you can to make that dark and cold. But really thinking about your routines. Sleep is a place that is really important to help our nervous system. Sleep has two major functions: to put memories where they need to go, yikes, right? Some of us have some memories that need to go somewhere. And also, so to consolidate our memory and to heal our body. So we need those. And next is, I think this little meme could probably, I think many people would relate to this meme, at least many people I talk to, I feel something, oh crap, I'm gonna go out of control. Or if I acknowledge a feeling, I'm gonna turn into a puddle, right? But we have to start being aware of our emotions instead of what most of us do is shove and keep moving. I don't know, okay. So we come back from the call and just get back to whatever we were doing. I understand that is the reality of the job, but where is the time and space that you have a chance to process what happened at work or on that call or with your family? Emotions are normal. Anger is normal. Fear is normal. Disgust, shame, all of those emotions are really normal. The problem is when we get stuck in the emotion. And I used to work with a police sergeant who said, you either have to pee it out, cry it out, or sweat it out, but it's gotta come out. Emotions need to come out. So we have to figure out healthy ways before we just bury them and then they show up sideways, like in pain or a physical problem. And also, everyone's favorite coping strategy is staying busy, right? Because if I sit still, oh my God, it feels terrible. So I've already mentioned this. Rewiring your system is a skill that you train for, not something you just hope for the best. You can train this. But one of the things I really like is thinking about how you transition from home life to work life and how you transition from your work life to home life, like in between home and the other things that you're doing. Perhaps it's 5 minutes of breathing in the driveway or throwing the ball for the dog right when you get home. And of course, work that out with the people that you live with. There was once a firefighter who said, yeah, I come home and I spend 4 hours in the garage and my wife's really pissed about it, but I'm doing what you said. It's like, okay, well, 4 hours in the garage really isn't the answer, and it's got to be a negotiation, but think about how are you downshifting your nervous system? Is there a ritual that might work for you? A shower, a hug, a walk, something that helps you get your body eased out of that. Music can be very helpful. Nature is extremely helpful. We don't always have that benefit in the middle of winter, but when we do, we use it. So here are some of my top recommendations if you're going to do anything. 5 ways to reset. There are many types, but using the breath for sure, and start small, right? We don't all have to be monks at, Buddhist monks that know how to sit for 2 hours and not have a single thought. That's not really realistic. And they will also say, actually, their mind doesn't stop. But maybe it's just 1 minute of breathing. Think about how you downshift your day, but really think about where you get intentional relaxation. So I don't mean where you kind of like stare at Netflix for the rest of the night, but really about, what's going to be relaxing if I read, or if I listen to this music, or if I do some stretching, right? So intentionally working with your body where you feel calm. We've talked about awareness and we've talked about sleep. And what we haven't talked about that much is actually what we put into our body, right? What real food you're putting in, because people tell me often like, oh, I notice if I eat these certain things, I feel like crap the next day, or I feel actually sluggish and almost depressed after I have cake the night before. Right? So it matters what fuel we're putting into our body. There's a whole host of other integrative ways, supplements, looking at blood work, and looking at what's actually happening in the body. But this is something we all have control over. Hydration helps too. But it's really about where we find and how we start intentionally flipping into that off switch. And sometimes when people start doing this, it doesn't feel that good. Right? So you might have to feel a little discomfort or buck the system to do it, right? So it's not normal, at least in departments I'm in, that people would be engaging in these kind of normal de-stress situations. I know there is a department I love, they do stretching together, and that is a wonderful way of them downshifting their nervous systems very intentionally. It's not just sitting in the recliners watching a show, it's really doing something directed to help their body start feeling better. And you might have to learn to say no, right? To some committees, some extra things, people asking you for help, even though you love them, they love you, and you're used to doing those things. No is also a flex. So yeah, I think my time is just about done. I'm happy to share these. This is a million other ways you might downshift your system. I'm not going to go through all of them, but they're certainly available for you to pick and choose. And there's many more that aren't on this slide as well. But please reach out if you have questions, thoughts, if you want more information on anything I've shared. Always happy to hear from you. Other than that, thank you for being here. Yes, great. And Parkinson's particularly. Yeah, great question. No, I don't know. That's my answer, is I actually don't know, and I haven't heard about that correlation. I think there's a lot of question marks about Parkinson's, but I don't know enough to answer that succinctly. Did you have another question? This guy? Okay. Okay, great. Maybe someone else knows something about Parkinson's. This is not me. Okay.
I'll maybe pick up from where we left off with the question. I had put a question in the online chat. So the question about link between Parkinson's and trauma, or broaden more into stress. And so there's a number of different models of how we think about Parkinson's. And there's a way in which we kind of think of things like Parkinson's or dementia as kind of the same. It's a neurodegenerative condition. Many points of kind of injury over, a 20, 30-year period across our life. And all of those little insults to the brain is thought of what leads to something like a Parkinson's or a dementia, and some of the other degenerative conditions as well. And a little bit of what makes the diagnostic label is where that starts. So for Parkinson's, It's like where that's starting in the brain is what makes it Parkinson's. Often Parkinson's left long enough will turn into dementia. Dementia is unlikely to look like Parkinson's, but it really depends on the type of Parkinson or the type of dementia and where and the changes that happen. So you could get a kind of Parkinsonian type dementia. So kind of many, many similarities across these neurodegenerative diseases. And one of the common links is understanding the protein alpha-synuclein, and alpha-synuclein being misfolded in the gut, and then it can travel up through the vagus nerve into the brain. So it kind of bypasses the blood-brain barrier where we would hope that it would get stopped, and it does. Although there's some changes that can happen to the blood-brain barrier that could allow that to cross. The main culprit really is that it's the vagus nerve that it follows up and gets into the brain that way. And then that starts off this inflammatory process that leads into, again, stages. So there's no one thing that we could pin it down to. It is a series of insults over a long period of time that lead to the outcome. So I think you said it well in your presentation when you talked about the changes to the gut and how stress can change the gut microbiome. That is very, very much being implicated in what they've shown in some of the Parkinson's studies when they do stress management and anti-inflammatory and treatments to the GI tract. It not only changes the microbiome in the gut, but it changes the bacteria in the brain and has an impact on lowering the symptoms and the progression of the disease of Parkinson's. So some really good models to show that treating the gut, even when the disease is there, helps change the course of the disease, but also knowing how stress affects the gut. And so we can't put it all together because the loop is too big and there's too many variables, but it paints a pretty compelling picture. Okay. So we're going to talk about neurotherapy and trauma. We always like to recognize the people that we have trained with and learned from. It says a lot about how we practice and the perspective we take on neurotherapy. Of course, one of the questions we always get is there research? So the answer is a resounding yes. There's more than enough studies to keep you busy if you wanted to go out and read some of the near 4 million studies now. Here we break it down into some of the categories and some of the numbers. So it does help, again, just show, kind of validate that everything we're going to talk about tonight is evidence-based and not just things that Fran thinks up late at night. There is some science behind this. So I'm going to start off talking about neuroimaging. And so the way I think about it often is, when I'm talking with people, I'll say is like, if you were sitting in an office with a cardiologist and the cardiologist was just asking you questions about your relationships and, did your mom hug you enough as a child and how did Valentine's Day go for you? You would go find another cardiologist because you'd be like, that is not telling you anything about the health of my heart. So you might do a stress test. And stress tests used to be the gold standard, and it certainly does from a functional standpoint. But really what you want is to have a calcium scan of your heart so that you just know how much blockage, right? No blockage, some blockage, the blockage that says you should have some type of a procedure, or the blockage where they just say, come with us and take you right down into surgery and you have a quadruple bypass. So imaging is what lets us know the state of the state. And so we often say that mental health is the only profession that doesn't image the organ they work on, and we want to change that. There is perfectly good ways to image the brain. Our chosen method is the quantitative electroencephalograph, or QEEG. And the reason that we don't do, say, something like MRI is MRI shows anatomy and not function. And what we want to see is the function. We want to see is, how is this little bundle of neurons talking to this bundle of neurons over here? How is that conversation going? How are networks or ensembles of neurons talking to each other? How are networks of networks talking to each other, so that we know how energy and information is moving around the brain and is moving around in a neurooptimal way. And that's what EEG allows us to do. So here's just an example. It's not uncommon, say in a conversation with a neurologist, for a neurologist to say that the EEG is just an epiphenomena of the brain. It doesn't mean anything, it doesn't do anything, it has no value. Still to this day, that is a common comment from neurologists. But here we have an example. This is just a small study that was done amongst many, where they took 3 participants and had them look at the top row of letters while they were reading the EEG. And then they did analysis on that EEG to pull out the image. And if you look in those columns, it is not hard to tell that the A is an A or the C is a C. And so, when we say is EEG, high resolution, full of information? The answer is yes. You can look at a letter and we can tell what letter. And there's other ones where if they're playing music, so that if they're doing EEG and you're listening to music, they can tell what music you're listening to. The sophistication has grown incredibly. So here, we're not looking at letters when we're doing EEG. So we got a couple of different images up here. So this top one, we would call this kind of a normal 1/F slope. This is a dysregulated 1/F slope. This is a little description of what is a 1/F slope, which is, it is the frequency, the occurrence of frequencies in a given bandwidth. And white noise is kind of all frequencies equally, so that's a straight line. Pink noise, which happens to be the background sound of the brain, the electrical activity of the brain, is like pink noise. It's more of a line from corner to corner. So a typical noise-based, so sound-based 1/F is going to be more of a corner to corner. But when we go to the brain, we'll see this big 10 hertz spike, because what a brain should do in a resting state is produce alpha, the resting attention. So the neurons are tapping their toes saying, hey, I'm ready to do something. If you need me, just call on me. So that's where we want most of our neurons to be doing when we're doing a resting state EEG. So this is an ideal. And then if we come here, we can see we have multiple peaks. So an overactive brain, the brain isn't as offline as it should be in a resting state. And then another piece that we take in is we look at biometrics. So we're not just looking at the brain, so the central nervous system, we're also looking at the autonomic nervous system. So we'll do a 10-channel data intake from the body. So we can see what the autonomic nervous system is doing, what the central nervous system is doing, and then comparing so that when we move into treatment, which Fran is going to talk about later, how we can do both a top-down and a bottom-up approach to regulating the nervous system. So here what we're going to look at is some EEG. And so this is a person that has been diagnosed with trauma, with PTSD. So we're looking at a brain that has lived the experience, and we're going to look at the impact of trauma, or some of the impacts of trauma as they show up in brain activity. And then we'll talk a little bit about what does that mean. So in this video, I'll be narrating over it and kind of drawing and highlighting some. So I'll just let this play. See here the biofeedback parameters that we will see more about later. Right away, you can see some spindling alpha, which we should not see in an eyes open recording. As we go, some slow wave activity in the frontals. Some more slow. See another big burst of spindling alpha. And some more. And there's a big burst of eyes open spindling alpha. Another big burst. There again. Again, another large burst. So we think of like spindling alpha should happen when eyes are closed, not when eyes are open. It's just a function of the brain. So when we see something that is in the wrong state, it's a problem. If we had time to analyze that EEG, there's actually, this person has multiple trauma markers throughout there. There are what we might call like epileptiform discharges. And so that's never good when you have that kind of EEG activity. The amount of dysregulation that's going to show up functionally, cognitively, but also into the body, since the brain is also running the body. So yeah, so it's a fascinating, from our standpoint, looking at this person's EEG and matching it up with their life experience and then how they're functioning in the world. Really didn't need to look beyond the EEG to see the significance of the dysregulation for this person. And then for us, it's how do we correct that? And again, Fran is going to talk with you about it. So this is a model from Dirk de Ridder that is showing this primary switching, which is the Salience Network switching between our executive function and the default mode networks. And what happens in the case of a PTSD, and Dirk is starting to put forward the idea that it could even be diagnostic for PTSD, which is a person, so if we're going to have the classification of a PTSD, it would be this is a main part of that, which basically says the switching is reversed. So things that would make a neurotypical person calm will have a person with PTSD will get activated or maybe go into panic, and vice versa. Something that I would find, might find irritating to my nervous system, overstimulating, somebody with PTSD will find calming. And part of that reason is because this switch gets reversed. And then he's added to the model a network lower down, kind of the emotional network, and talked about how if the emotional network is dysregulated, that can then affect the salience network or the switch. And so if we look at the person looking at some of their network function, you'll see the one that I've highlighted. So AD is average dysregulation or standard deviations away from a normative database. So an age and sex matched normative database. So 7 standard deviations dysregulated. That's a lot. Clinically significant is considered anything over 1.6 standard deviations. Typically in the clinic, we think 3 we're interested, 3 standard deviations. 7 is a lot. And here it is in the emotional memory network. So this maps well onto the model that Dirk de Ridder has put together. So here, the main thing here to look at is the SDNN. So this is heart rate variability. So at 27. So for an adult, a range of 40 to 60 is normal. And so nobody really wants to be at the bottom range of healthy. And then here being 10 points below that, this is quite significant. And SDNN is your best predictor of all-cause mortality. So think longevity. The lower your HRV, the shorter your lifespan. And so 30 is concerning. Here, looking at some of those 1/Fs that we talked about. Let's see, I think I've got, we'll come back to those. There's a pattern here that's called a mu rhythm. So right here, we see a mu rhythm. It's a common response to trauma, way of for the brain to kind of go into a frontal lobe disengagement or a dissociation. Person kind of goes into their happy place in their mind. Here we're looking at from a event-related potential, a P300. What we should see is a nice smooth curve of activity going up and going down, peaking at 300. But we can see we have kind of almost like spasms of firing as the brain fires in this kind of disrupted pattern. So it just tells us again that the information is not moving around the brain in a nice smooth fashion. And so we would expect to have dysregulated behavior, but also, again, because the brain spends most of the time running the body, we're going to see most of the dysregulation show up in the body in the form of health. Here we're looking at network functions. So how are the various networks doing? 0 is good, 10 is not so good. So you can see we've got a number of the really core networks are not doing well. So salience, working memory, the reward network, a mirror neuron, language. So a lot of dysregulation in the networks of the brain. Here, peak alpha frequency. What we should see in that center column of numbers is ideally it would be 10s all the way down. That would be kind of a neurotypical. But here, this person's peak alpha frequency is probably a little bit more than 10. Naturally, once their brain was synced up, I would guess that they would be a little more than a 10. But you see those 7s. So again, frontal lobe slowing. And so this person this person lives a life where they know that they dissociate about every 30 seconds to 60 seconds. They dissociate for a few seconds. They've lived their life around it. But as an adult in the world, that is not a normal, healthy adaptation. And it may have been helpful going through the trauma, but now they're on the other side of it. It is not a helpful adaptation, and it's definitely impacting their ability to succeed in the world. So here's one of those 1/F slopes, and you can see it does not have that nice, clean pattern of a single peak and then dropping off. We have multiple peaks. So this is a brain that's very much in distress. This one is another pattern that's occurring in the same person. This is kind of a classic treatment-resistant anxiety. We see this pattern is in people who have not had good luck with mental health, have not had good luck with medications, and that despite multiple medications and years of therapy, their symptoms persist. And this is a treatment-resistant form of anxiety. And then it's Fran's turn. Okay, Fran is going to come and tell you now, what do we do about all of that when we do our neuroimaging and we find those things? Then we want to treat it.
So, holy cow, I was just feeling like this should have been 4 hours because I wanted to hear more of Dr. Gavian's stuff, and I want a guy to talk a lot more about just kind of what happens in the brain with trauma. But we'll do that another time. So my task here tonight is to talk a little bit about the kinds of things that we can do to work with the trauma dysregulated brain that Guy has been talking about, and that Dr. Gavian did a really nice job of really kind of highlighting the symptoms, the full body symptoms that can occur. And so I'm excited because I want to talk with you about some really easy interventions that can really start to help address those. So we're going to look at some top-down processes, we're going to look at some bottom-up, and then really kind of talk about metabolic processes or interventions that we can use as well. So we're going to what I really want to do is really highlight this idea of sleep with what I'm going to talk about with the AVE, sleep and emotion dysregulation. So Dr. Gavian talked a lot about the role of sleep and how that gets impacted. You all know as first responders, when you work shift work, quality sleep is not a thing, right? And so it can be difficult to fall asleep when you're at home, when you're not in the station, and to have restful sleep is a device. And I feel like I'm going to switch back in a minute to the other slide, but this is a device called an audiovisual entrainment device. It is a set of goggles. You can see either view through goggles, or we have opaque ones that are so that you don't see anything. For some people prefer one over the other. And headset. And what audiovisual entrainment is doing, this device is pulsating light and sound at a particular frequency into the brain. The frequency depends on what protocol you're using. So the device itself has built-in protocols for sleep. And so if you were using this at night, you would just click that protocol on. And what's going to happen is the light is going to start pulsing through the goggles. It's going to hit your brain, hit the optic nerve area. It's going to start coaxing the brain, the neurons in that area, to start mimicking that frequency. So we might have a theta frequency or moving into more of a delta frequency. Once those neurons start mimicking, they sort of start to encourage their neuron neighbors to do that. And it just becomes kind of this state in the brain of quieting down into that theta wave frequency. And then what that can do is bring the brain that can't get to sleep into sleep, or the brain that wakes up all night long is having difficulty with a quality of sleep, getting into deep REM sleep. That's what this device can be helpful for in regards to sleep. It's also got ear clips that do cranial electrical stim. So it's a little bit like, if you think about like alpha stim, something like that. What that's actually going to do in this particular device, because it's not particularly powerful, but it's going to enhance oxygen blood flow to the brain, which can be extremely useful in helping the brain to kick into using its frontal lobe to emotions. And so the other place where this device comes in really handy is in regulating emotion. And so it's the kind of device that I wish every station had these devices available for when people, responders come back from calls, whether it's the really, tough car call or the tow that Dr. Gavian talked about that just is so irritating because you just woke me up at 2 a.m. for a tow issue, right? That kind of a thing. But to kind of settle down that nervous system, there are protocols in here. I've seen it take somebody in my office who is in a literal full-blown panic attack and get them to a calm state within 5 minutes. And then you just run the protocol longer and it continues to get the system moving into more of that, producing more frequency that leads to the calming state. So audiovisual entrainment can be an amazing way to work on regulating some of the dysregulation. It is a treatment protocol, so it's like a paradigm that is about treatment. And so it's the kind of thing that you would want to use every night as kind of a tool, at least the nights when you're at home. This is tougher to use for sleep in the station because of the nature of having to, wake up if there's a call, but certainly really good for at home. I'm going to show you this video quickly. This is a video that shows how quickly brainwave frequencies can change when the audiovisual entrainment device is started. So you're going to see we have a tech hooked up to his monitoring his EEG, and then he has just, when we start this video, he has just started an alpha protocol. I chose an alpha protocol because you'll be, like you saw it with the EEG that Guy was showing you, you can see the change in the EEG pretty quickly. So I just want to show you how quick of an intervention this can actually be. So right now, we're just looking at him. He's wide awake. He's thinking about something. We see some beta wave going on. Here's some fast beta. And you can notice that we're about 58 seconds in. Now we're at a minute in. And pretty soon, what you're going to start to see is some slower frequency kick in. So you start to see some right here. That's alpha wave kicking in. And we are at a minute and 12 seconds into the device starting. That's how quickly the brain can start to respond to this kind of cajoling it by giving it the kind of saying, do this, giving it the frequency, and then it starts responding. And you'll see, I love this video, like within less than 2 minutes, we start to see a brain just full of alpha wave. So here you start to see it really showing up there. And so for somebody who is, in a state of really a heightened emotional experience, somebody who's in a real sympathetic state and stuck there, this kind of gets the brain to move out of that, right? So it can be a really useful tool for helping with that. And then I'm running through these really quickly, but Guy had talked about heart rate variability. He had showed you the SDNN and talked about it being kind of the primary marker for all-cause mortality. So we know with first responders that cardiac health is a real issue, right? That there is a lot of struggle with that. HRV has been correlated strongly with that as well. And this is a practice that you can engage in no matter where you are. Every firefighter I see goes through an assessment for heart rate variability, and we download an app, and their homework is to use that app to train themselves to start breathing at what is their, we call it a resonant frequency. It's the number of breaths per minute in which their autonomic nervous system functions most optimally. So we can, we'll take a look at, I'm going to show you the video. I think I'm going to skip through it just because I'm guessing time is going to get close to the end. But I'll show you a video of neurofeedback where we also are looking at heart rate variability training with that. And so you'll get a chance to see that. But this is extremely useful intervention. This is also one that can be good for sleep. And this is one that can, like 10 minutes of doing heart rate variability before you go to bed can really calm your system down. It works really well. I will tell you from personal experience that if you are struggling with blood pressure and you engage in a regular, consistent practice of heart rate variability breathing, you can regulate the blood pressure oftentimes that way. So before I move on from the heart rate variability, so it's useful to figure out what your particular or specific frequency is. It's typically in adults 4.5 to 7 breaths per minute, somewhere in that range. If you're not able to figure out your resonant frequency because you need to come get wired up, like in our clinic, to do that assessment, the kind of average is 6 breaths per minute. And even starting a practice where you are breathing at 6 breaths per minute can start to enhance heart rate variability. Okay, so the next thing I want to talk with you about, so those are 2 interventions that can be done for kind of without having to go anywhere. You get a device, you use the device at home, you use it at work, you can breathe pretty much anywhere. And so those 2 are like for first responders, those are like, for me, necessary interventions that they should be thinking about. Then we can look at doing something that really is going to hit at what Guy was talking about with the networks, like the Salience Network and the memory or the emotional network, the executive network. We can do neurofeedback training to work on regulating those. So he showed you the client with PTSD who had her emotional network was 7 standard deviations above the norm. We can train that network, and very often that's what we do in clinic is we train it and we move it down. We can literally watch it go from 7 to 6.5 to 6 and so on. And as that network regulates, then it's much better able to engage in the tasks that it is responsible for in regards to kind of its role on the team of the brain, right? And so it can, all of those kind of symptoms that we might see that are trauma related can start to subside as that those networks start to be trained. Here we go. And I'll just kind of walk through a little bit of this. I don't think I'll do the whole video just because we don't have probably time for that. And I may pause a little bit just to show you a few things. Whoop. I guess that doesn't pause it. I'll show you a couple of things. Okay, so a couple of things to point out. He's wearing an EEG cap, and so there are sensors there that we're reading information from all those areas of his brain, getting fed into a computer that has a database of kind of neurotypical brains that are matched for his age and his sex. So he's getting compared to pure brains that don't have much dysregulation in them, right? So they're functioning optimally. What you see him doing is he's sitting there and watching a video game on a screen. The video game isn't, you'll also notice he doesn't have any video controls in his hands, right? The video game is being controlled by his brain. His brain is playing the game, not his mind, but his brain. And so as the computer starts to read what's happening in his brain, whenever it notices his brain behaving similarly to the database of neurotypical brains, it's going to have the game be successful, right? That we're operantly conditioning the brain, right? And so what you're going to see happen here is you see the target on the screen, that fire ring there. And the goal of the game is for that plane to go through the target. When it does, if it hits dead on, that's because his brain is doing the behavior we want it to do. It flips over, so there's a visual stimulus, and it makes a swishing sound, so there's an auditory stimulus. The stimuli are the reward for the brain, and then the brain wants more. And so it's likely to do that same behavior to get more. And so this is what, as we do this, we're literally teaching the brain to behave differently for the long run. Yep. And so this is changing the brain permanently. So unlike what we could do with AVE, with neurofeedback, we can really create some permanent change in neural circuitry. And then you can see over on the laptop screen there, the whole time we're watching the EEG, we're looking at how many metrics of dysregulation there are. So right over here, you can't see that. Yep. You can see a lot of metrics of dysregulation here. We can see here how many standard deviations above the norm we are training him at because he's got all of this dysregulation. Over here, we can see head maps that are different frequencies, delta, theta, alpha. We can tell whether there's excess or deficiency happening while we're doing the training, and it informs us in terms of what we might want to do with the training. Are we training too easy, too hard? Are we spot on? That kind of thing. There you just saw his brain get rewarded. And then I'm going to move over here quickly, and I'll just pause it here for a second just to show you a little bit of what, when Guy was talking about heart rate variability and the SDNN, that kind of thing, these are the metrics that we look at measuring for heart rate variability. So we can train somebody to do some breathing while we watch. This is their autonomic nervous system, all of the metrics that we can see here. And we can pay attention to what's happening with them in terms of their autonomic nervous system. And then if during neurofeedback we're noticing that pretty dysregulated, we can also take some time to stop and do some training of that. But it just gives us more information on, as we're training, of what's happening in this system. So we're looking again at the brain as we're doing the neurofeedback, and we're looking at the autonomic nervous system as we are monitoring those metrics. So I'm going to move past here. Well, let's see if he's successful. Oh, there the brain just didn't do quite what we wanted it to do, and so it did not get rewarded, and so it's going to try harder again, right? And so all he's doing, his big job is to sit there and stay focused on this. And so over time, what we can do is train those networks then to become more regulated. Then this slide is talking about another intervention. This is photobiomodulation, or red infrared light therapy. There have been some pretty recent studies where they've looked at first responders using red light therapy. And so we didn't spend a lot of time talking about this tonight, but one of the things that happens with trauma is, thank you, inflammation can occur, and that's a very common thing that we see with people who have any kind of trauma, whether that's kind of like a PTSD kind of trauma, a concussive kind of trauma. Oftentimes with first responders, they have both. And so red light therapy has been shown to be very successful at both decreasing inflammation in the brain, but also then enhancing ATP, like the energy producer in mitochondria. So, and that actually, when trauma happens, there's research that shows how that ATP gets kind of shoved out, like the cell gets holes in it, kind of, and some of the ATP gets lost. And so the photobiomodulation is a good way to start improving that. You can see this guy over here has a red light helmet on, right? So we have those in the clinic, and we oftentimes will use those in conjunction with other training that we're doing. It can be really helpful in terms of kind of, again, addressing that stress, but also sleep. And then this slide, so this would be my ideal for every first responder that I see for sure, but just in general. But this is kind of an example of how you can use interventions that address both the brain and the autonomic nervous system to work on not only managing the symptoms of trauma, but making changes, like true long-lasting changes. So this is just an example of what you might do. You could throw on a helmet in the morning to do some photobiomodulation, and as you're sitting under the helmet, you could do some HRV breathing here, like do 10 minutes of HRV breathing. What the research shows is somewhere between 10 to 20 minutes of HRV breathing practice per day is the optimal to start training your system to breathe at that optimal rate as its more baseline rate. So then you might do that, and then when you're done with your shift, you might use the AVE as a way to kind of calm down. I was thinking about what Dr. Gavian was talking about in terms of that downshift, right? This is where an AVE could come in real handy, that you could, before you go in, and you could either hang out in the garage, you could go into a room in the house that you've already talked with your family about. When I'm done and I get home, I'm going to take a half hour, put an AVE on, and run a protocol, and after that, I'll be fully engaged in the family, right? As a way of sort of signaling the body to kind of kick in that parasympathetic response and get you more calm and ready to do the interactions that you all are wanting to do with family and other areas of your life. And then while you're doing the AV, it wouldn't hurt to do 10 minutes of the HRV breathing again. So then you're getting your 10 and 10, you're getting 20 minutes, and you don't have to spend just 20 minutes doing the breathing thing. And then that could be kind of the daily process. And then if you really want to make the change that is going to really be permanent for you, the idea of doing neurofeedback becomes a really useful tool, right? But this is an in-clinic process. Most, like the 19-channel neurofeedback I'm talking about, where we're training those networks. You're in the clinic, you come in a couple times a week for 40 sessions so that we're creating some new neural circuitry that your brain can kind of solidify. And then what's really cool about neurofeedback is, and there's good research to back this up, is that once we've kind of helped the brain with neurofeedback to kind of create some of that circuitry that's more optimal, your neuroplasticity is just going to run away with it then and just continue to make it a stronger route of optimal functioning. And then I included these in here. I will mention, I put this in the chat, but I will mention that we'll share both Dr. Gavian's slides and our slides with you, and so you'll have these information. She had a really extensive list of things that you can do, exercises you can do that are pretty simple to do and can really kind of get you, kind of do that downshift and get you into more of a parasympathetic mode. The slides that I have here are some of that same thing, addressing kind of from a polyvagal standpoint, looking at addressing the vagal nerve, because what we know about it is that it really is responsible for kind of talking to the parasympathetic nervous system and getting it back on board. And there are many exercises that you can do that can trigger the parasympathetic system through the vagal nerve. Those are just a few. And then there are some somatic experiencing types of practices that you can do that aren't particularly, like, nobody wants to be sitting in the, at the station doing weird stuff that looks weird while the rest of their crew is around, right? But these are the kinds of activities that you can do anywhere. Your whole crew could do them if you could get them to do that. But you could, go in your room for 5 minutes and pull out and do a VU breath while you're pushing at the wall as a way of kind of grounding you and at the same time kicking in the parasympathetic nervous system. So lots of options in that regard. I think Dr. Gavian would say this, but I know we are always happy to share more information about that if you'd like. So this is the idea that, when you have trauma, it does not have to be a life sentence, even if you work in an environment where it is kind of nonstop opportunity for trauma. I love how Dr. Gavian talked about the traumas that most lay people don't think about that happen for first responders. The stressful environmental traumas, not just the calls, but the ones that are the medicals, right, where you go and somebody really doesn't probably need to have a first responder there, but you're there. But also a lot of the dynamics that go on either within a station or within a department can be extremely stressful as well and lead to that experience of trauma. This idea that I think we all have been sharing tonight is that it does not have to be a life sentence. It doesn't even have to be a way of life, that there are things that you can do to work on modulating your system, whether it's your autonomic nervous system or you're working more with your brain, to really kind of create more of an ability to be fluid in your life in a way that doesn't have the negative impact that oftentimes we see with trauma in first responders. All right. Thank you for your time.
Yes, thank you for the question about MS and trauma. And so the linkage is going to be somewhat similar. So MS is not in the same category as something like a Parkinson's or a dementia. Not that it isn't a neurodegenerative condition, but it is in a completely different way that it is a neurodegenerative condition. It tends to be much more contained. We get smaller lesions. It could be in the spinal cord or in the brain. So MS is got a very different profile than the conditions that I was talking about, but its kind of etiology can be the same. It's a slow ramp up over a long period of time that is these multiple small insults to the body that lead to a breakdown in our core protective systems that then presents as a disease. And then we kind of want to look right around it and say, well, what caused it? I didn't have it yesterday, but I have it today, and think that the cause is proximate. But actually the cause is probably the previous 20 years of one's life. So exposure to environmental toxins. We talk about first responders. We maybe don't always think that they are exposed to environmental toxins at rates the rest of us are not generally. And so that is also part of just the risk of the career that happens. So exposure to environmental toxins, so just environmental stressors, poor diet that leads to inflammation. These are more like at the root. But of course, when trauma is involved, two things. One, it has a deleterious effect on our system, but it also has a draining effect on our resilience. So our health and vitality isn't there to push back against these factors. So it's kind of a double-edged sword. We're getting, we're having two negatives, the kind of the toxic experience itself, but the absence of our resilience to push against it. There are two sides to it. So I think there's an absolute link, but it is going to be a different link than what I talked about in the Parkinson's and dementia. All right, so it looks like the questions have been asked. So thank you. Thank you, everybody that made the time to show up. Thank you particular to our online folks for joining us. And we hope to see you again. So first Tuesday next month. Actually, I think we're going to be talking about Parkinson's. We're going to be talking about neurotherapy and chiropractic care for Parkinson's. It'll be equally exciting. There's a lot that's happening in that space. We have some really good interventions for Parkinson's. So we'll see you then.